Good morning, or it's good morning in Memphis. Um, I'm Dr. James Fleming at the Hamilton Eye Institute at the University of Tennessee in Memphis. You can see this on the slide. And the topic we've chosen today is thyroid eye disease or Graves' orthopathy or Graves' disease. Many different terms are used for this process that we all as ophthalmologists tend to see. The plan today is to do an overview of Graves' ophthalmopathy, and as CyberSight is requested, we have a series of questions embedded within this lecture. Those questions you can answer, and I'll get a feedback on the thought about this. So let's begin. And if you'll give me just a minute, I'll get my slides going. First, financial disclosures, and I wanted to put this is I do a lecture for AO North America, a lecture in orbital fractures. I donate all that money to charity. The second has to do with thyroid eye disease, and I've been involved in a phase 2 double-blind study for active thyroid eye disease. I guess the short answer is I'm trying to work myself out of this business, as we all probably are, but we'll get into that a little later in the talk. A text was written by John Dutton and Barrett Hike a few years ago. I've contributed a few chapters to this text. That's the basis of when we started talking about thyroid eye disease and its diagnosis and management. So the first polling question is, what is the usual age of onset of thyroid eye disease? So I ask the audience to vote. And since this sometimes doesn't, there A, B, C, and D. I can't vote, the panelists can't vote, so let's see what the group says. Okay, the group answer, and if you're looking at the results, 30 to 40, 55%. Let's look at what the statistics show. And instance of epidemiology of Graves' orthopathy or thyroid eye disease is probably in the United States is 4.4%. I learned years ago the different populations, this goes up and down. I was in the country of Panama and found out after a talk there that it is rarely seen. And so this varies throughout the world. Male to female ratio is, as you see here, 0.5 to 6 to 1. Usual onset's 40 to 50s, but as the group has voted, this varies fairly significantly. It's the most common orbital disorder affecting a number of people and the most common cause of exophthalmos that we see. Historical background, 3 people have really been credited with describing this syndrome, Dr. Perry, Dr. Graves, and Dr. Bastow. How it obtained the name Graves' disease is an interesting literature read, but it did, or Graves' orthopathy. And so we've known about this for 2 centuries. Even though we've known about it, the science has really just begun to really move forward because of the autoimmune complex within this. And that's the next point I'd like to make is I'll use different terms throughout this because people use different terms. The fundamental cause is an autoantibody that binds to stimulate probably the TSH receptor on the thyrocyte. It's thought of by some researchers a while back that this was an IgG molecule, but other people may think other thoughts about this. We know there is a genetic predisposition. It's not Mendelian genetics, but it tends to show up more frequently in families, and we'll see that. The other one is there's a known environmental factor that worsens the Graves' ophthalmopathy, and that is smoking, and that's been shown in a number of literature articles. So classic theory of autoimmunity, and let's see if I can get my pointer to work. Antigen presenting cells are activated by some type of thing, outside source. This binds to T cells, T cell activity. In autoimmunity, we see death of tissue or injury to tissue, as in this cartoon shows. Classic example is rheumatoid arthritis. You get all this autoimmune event, and then you get scarring and the arthritides that are associated with this. Thyroid eye disease is a little bit different. The T cells interact with the thyroid cell receptor. So you have antigen presenting cells, T cells activation, and then there's upregulation of the thyroid. And so it independent of the normal regulatory pathway. So the next polling question is, thyroid eye disease and this upregulation affects the orbit as a secondary target organ. So what does it do? Does it increase orbital fat? Does it cause swelling? Increase the thickness of extraocular muscles? Or all of the above? And I'll leave it to our participants to vote their choice. Very good. It's 84% say that. If you'll notice, all of them, it's there, and nobody said cause swelling, and I'll talk about that a little bit. And so the autoimmune mechanisms are really unclear, and if you look at the bottom of the slide, there's been some thought about IGF receptors on the surface of the fibroblast, and it's an insulin-like growth factor, but a number of people are working toward what is the autoimmune mechanism. It has still not been well or clearly elucidated in the scientific literature, but we're a lot closer than we were 20 years ago. So what indeed does happen in the orbit associated with this? And what happens, it appears, that have been identified is orbital fibroblasts appear to be the prime target of this autoimmune attack. The cell that is noted, it's the retroorbital periadopocyte fibroblast. These cells undergo adipocyte differentiation, and there has been measured increased orbital fat in a subset of these people, and we know it. Classic other places is the brow fat pad increase, and that's been reported in the literature fairly often. T-cell mediated inflammatory response, or the inflammation, is occurring in the active form of the disease. So we see swelling and inflammation. In acute orbitopathy or thyroid ophthalmopathy, we do see swelling and inflammation. I've got some photographs of people with this. And the last, the increased thickness of extraocular muscles, or the elaboration of glycoaminoglycans, causes thickness within the muscles. And this is deposited, it's been shown pathologically to be pretty common to see in the group where you see enlargement of the muscles. This is a schematic of thought of what's going on. It's from Dutton and Hike's book in 2002. Antigen-presenting cells activate T cells. It upregulates the thyroid. Whatever this T cell activation gets into the bloodstream, it finds the fibroblast in the retroorbital area, and then the three things happen. What you get is edema, thickness in the muscles, proptosis, collagen synthesis, fibrosis, restrictive myopathy, lid retraction, which we see, and then increased orbital fat and proptosis. So all of these processes go on in the secondary target organ. The other secondary target organ is pretibial myxedema, and all of us see this. This is probably only in 4% of the people that have this problem. So in looking at who gets what, the best population-based study that I could find or come up with was out of the Mayo Clinic. George Bartley put this out in 1994. The county right around Mayo Clinic has been studied for many years. So he pulled that whole population. Now it does have an increased instance of thyroid eye disease, but the findings associated with this are pretty clear what you see, and it follows most people's experience and practice. Lid retraction, 91%. Exophthalmos, 63%. Restrictive myopathy, double vision, 42%. And optic nerve dysfunction is the key one. 7% has really been put forth, and it tends to hold clear in most of the literature. When they did do CT scans, they found 55%, not 63%, had extraocular muscle enlargement in the group that they looked at. And then the most interesting piece is, and this is an argument I have with endocrinologists fairly often, can you be euthyroid and have Graves' orbitopathy or thyroid ophthalmopathy? His finding in a very systematic population-based 7% of the population that he looked at was euthyroid at the time they were tested. Now they may later come to thyroid ophthalmopathy, but this is what the data showed at that time. And it's a pretty clear study of the kind of how this appears through time. So the clinical course of thyroid eye disease is also the thing we need to do. And I use the term Rundle's curve. And Rundle was an endocrinologist in the 1940s. And he pretty well described the orbitopathy portion of this. And so how long does Rundle's curve last? And so here we get to vote again. So the group can vote. And, you know, when you have an onset of thyroid eye disease, what are we looking at? And this is the kind of the outlook for a patient, your prognosis as what they can expect to happen. So I'm waiting patiently for the group's vote. So 6 to 24 months was 62%, 30% think it's like maybe 6 months, and then a little bit on both sides. Nobody thinks this is 2 months, and they're absolutely right. So let me close that. So here's what's been kind of reported, and I pull from the literature, and that is Rundle's curve, and this is the active phase and the chronic phase, and people talk about active phase and chronic phase. And if you divide the active inflammatory phase, you can have acute or subacute, and that means they can be really hot, really inflamed, redness and inflammation, or this can be a slow progressive thing. And so the active phase that everybody's talked about is usually around 6 to 24 months. It's kind of holds up in the literature. However, the caveat is this is quite variable. So it varies from patient to patient, and we've all seen this pretty commonly. There's a variable outcome in this group of patients. The chronic phase or the fibrotic phase that these people have gone through Rundle's curve and they're at the other end, then the question comes down to what's the long-term prognosis? In my review of the literature, really 2 long-term studies have looked at proptosis. I haven't looked at the extraocular muscle stuff and whatever. I just picked out proptosis and said, okay, what happens after they go to the chronic phase? 72% stay the same. Their proptosis doesn't change. Increase by 23% slowly over a period of time, and it decreases by only 5%. So, hey, it's going to get better because we fixed your thyroid gland and it's all going to go back to normal, is really hasn't held up. So let's look at my drawing of Rundle's curve. And I use this in clinical analysis of patients. Rundle was pretty good at describing this. What happens is if you have a patient, the question I always ask, where are they on Rundle's curve? Are they here? Are they here? Are they here? But most likely they're not going to return to baseline. So what happens is you're following these people and you're trying to determine what's going to happen. And the classic answer I tell the patient the first time I see them is I will do measurements. I will find out where you are, but I have 1 point on a graph. I can do a little history back and forth. I can look back at their ID pictures from 6 months, a year ago, and get some sense of where their proptosis is. But in a clinical setting, the best way to do this is follow them. And so do a measurement, and my usual follow-up is 2 to 3 months, unless they have acute problems. Measure them again and try to isolate them on this curve and say where they are. The thing I'd like to say is this whole space under the curve is the variability. Some people can have it very severe. Some people can have it very mild with certain changes. If we go back to George Bartley's study, 91% get lid retraction. That may be their Rundle's curve. They may not have any other findings associated with this. The other question is, what are the reported risk modifiers in thyroid eye disease? What has come out over the last 10 to 12 years? And I'm going to put these 3 things up. I'll discuss each one of them a little bit, but I'd like everybody to take a shot at what's going on here with these 3 entities. Do they think one of them stands out? All of them are involved? Whatever. So let's see the group. You know, it's interesting when you do a webinar, there's no feedback except what I see over a period of time. So I'll just be patient and look. And here we go. 64% all of the above. There are a group of people that think low selenium levels thyroidectomy. So let's look at the literature. The first thing I'd like to say is risk modifiers are not causality. And I have a daughter that works for the Center for Disease Control, and we have this discussion all the time. Correlation does not equal causality. So there's correlation with problems, but that's not the cause, but they're factors that you must take into account when you're looking at it. And the classic one is cigarette smoking. And that has been confirmed on multiple studies when they do analysis. They need to stop smoking. The severity of their thyroid ophthalmopathy is going to increase significantly if they continue to smoke. So what about the other 3? Selenium. The European group reported a number of things, and that's the reference down below, 198 subjects, and they found that there was a decrease in selenium levels. And if there is a decrease in selenium levels, there probably is some help in dealing with that when corrected for this. It's not causality. Does it affect the outcome? It may well. If you test for selenium, this is a fairly easy medication to obtain in vitamin form, so that's something to consider in your patient population. Statins. This is the data from JAMA Ophthalmology in 2014. They reviewed 8,404 beneficiaries of a large managed care network and looked at statins. Patients that used statins for 60 days or more had a 40% reduction in the hazard of developing Gray's orbitopathy. Again, it's a retrospective analysis of data. It really doesn't create causality, but there is some correlation associated with this. There's one other caveat with statins and steroids, and I'll get into that in just a minute. So is there some correlation? Yes. Causality? Probably not. Thyroidectomy. This is the other one that was looked at in this large study. Same thing. Patient with Graves' disease who underwent surgical thyroidectomy had a 74% reduction in their hazard of developing thyroid eye disease. If you go to the endocrinologist websites, that is not the driver to have a thyroidectomy. There again is some correlation, but again, causality and correlation are two different things. So I pose it for the audience to look at, to compare, but understand that those three things are not drivers in this thing, but there's something to be considered in an individual patient. There is some correlation associated with this. So let's look at active phase disease management. So we have an active phase, and I'm going to take a second to talk about active phase disease diagnosis. And I think some people, I didn't put it in this talk because of the length of the talk. I use clinical activity score to delineate active phase. You go and iTeds, and I'll give you their notations or websites so that you may look at those. They both put forth modified ways to look at thyroid eye disease and use a classification. Clinical activity score has been very good for me, but I'm not bought into anybody's measurement except to say I continue to use the same one because I can compare apples to apples and continue to follow these patients over Rundle's curve. I'm trying to delineate where they are in Rundle's curve. So back to the active phase disease management, medical therapy. Obviously, localized ophthalmic protective measures, artificial tears, if they need to patch at night, if they need to do different things, use lubricants, that's what we do. Anti-inflammatory treatment, corticosteroids have been used by a large number of people. Oral periorbital injections have been proposed, and then IV pulse steroid use. There is some correlation, and this is the caveat I put in there. Therapy with statins and IV pulse steroids together puts somebody at a moderate risk associated with this, so some people need to take that in consideration if they're dealing with statins or the patients on pre-use of statins themselves. Immunosuppression, we hope that this was going to change the world. In my experience, this has not been the great savior we wished it to be. Others may have some different experience, but consistently, it has been not as good as I would like to have seen it. And targeted immunosuppression, we'll get into that a little bit later. Orbital radiotherapy, it's controversial, but it does have defined benefit with this. And then surgical intervention, I try to save for the chronic phase. The people that have had chronic changes, they're burned out, they're not an active disease. The only group that you do active intervention with are the people that have acute vision loss and you're not able to deal with it. I'll back up to the steroid therapy for acute orbitopathy with vision loss. I usually go to 60 to 80 milligrams of oral prednisone for a week, 10 days for the acute vision loss and try to control them in that fashion. I may jump to a orbital decompression if vision's going downhill. I have no problem with pulse IV steroid therapy, and I've got the dose in another couple of slides to put forth, and you can use that also. To give this group, UGOGO is the European group on Graves' orbitopathy. Go to their website. You can get further information. As I've shown earlier, there's whole text on this problem. So what I'm trying to do is speed through some updates and give you references to go further. The other one is ITEDS, the International Thyroid Eye Disease Study Society, and that group is right there. That is their logo, and I invite everybody to join and look at that information also. So let's go into acute orbitopathy. Severe exposure, compressive optic neuropathy, globe prolapse, real trouble. And this is a very small subset, as we talked about a few minutes ago. That's 5-6% of the people at best. And what it is been defined as is an orbitopathy. It's a compartment syndrome. Here you have an orbital compartment and you're compressing this compartment. There's compression of the optic nerve. There's marked proptosis. These people are in real trouble. They can prolapse the globe in front of the lids. Real trouble. So the question is, thyroid eye disease affects the optic nerve dysfunction in what percent? And I may have given away the answer. So y'all get a free one on this one. And the interesting answer is it's a physical problem. It's not directly within the optic nerve, in my opinion. Other people may say there is some dysfunction within the optic nerve, but it's interesting. If you perform orbital decompressions for acute optic nerve compression, you do get a significant problem. So the group agrees with me. This is a 5%, 6%, 7% group, small group, but really the intense group that you have to really treat hard. So the acute orbitopathy, they improve with oral steroids. I use 60 to 80 milligrams. You can dose it at 1 milligram per kilogram per day. The pulse therapy is at this level, it's 500 milligrams over 3 days and 4 cycles, total of 6 grams. I put the risk factors. There have been a couple of reported liver failures associated with this. If you're adding statins, look out. The combination of the two can give you trouble. And then acute orbitopathy, I do not like to do surgical decompression in this group, but if it's necessary, it's necessary. It's interesting, the slide I show here with the papilledema, because of the posterior aspect of this, papilledema is not the most common thing I see. It's the optic nerve dysfunction measurements that you pick up. So don't wait for the papilledema. Measure the optic nerve function and look for that group of people. Etiology, congestion with a compression of the optic nerve. So here's that slide. If you look at these extraocular muscles, glycoaminoglycans, the infiltration of this thing, and look at this poor optic nerve, it has been compressed within the apex of the orbit. Decompressions address this because of the thinness of the bone in the medial area, but this is a compression phenomenon associated with this. Can you decompress this medically? Sure, and we need to try with that. The other caveat I'm going to put in this talk is acute active phase disease management, steroid therapy. This is a very nice lady that a endocrinologist put her on 60 milligrams of prednisone for 2 months, and 40 pounds later, hypertension, diabetes, you name it, she's got it. A very unhappy patient. Have we shortened her life? That is a very good question. How much do you use steroids and how hard and how long is a question each practitioner needs to balance between the side effects of the steroids themselves. Radiation, to get into this, this is the dose. It's 20 gray delivered to the entire bony orbit. It's fractionated over 10 days in our community. There's other ways to do this, but this is the range in which it's used. Does it work? Sure. In my experience, it works for the acute inflammation. It takes a few weeks, so you're going to use this for acute orbitopathy. You've got to manage them with steroids also, but you can decrease the inflammation. But the point I'd like to make in this talk is, look at the proptosis. It's not gone. you really haven't changed the extraocular muscle dysfunction. You haven't really changed the proptosis associated with this. Now, the argument will be made, you didn't get them early enough and you didn't stop them before the proptosis became there. That is an argument that is made. So you start looking at the literature, and there have been 2 prospective trials. There have been a number of retrospective trials, and retrospective trials are great, but there's a bias already built into them by somebody's treatment modalities that they pulled out. So do a prospective trial, and I believe it much more. The first one is out of the Mayo Clinic in 2001, and the arguments made about this, they said there was no difference in use of radiation. The problem with that trial, many people pointed out, is they didn't pick active disease versus chronic disease. So they weren't separated out in that fashion. So there may be some flaws in the analysis of these patients, but they found no difference. Journal Clinical Endocrine Metabolism 2004 was the Netherlands study. And in that group, they did show a response to radiation. In the long run, did it change the course of their Graves' orbitopathy? That was in question, but it did decrease their inflammation. In their paper, there was a cost analysis and a change. And I invite people to read that paper to look at it and see what the cost and the benefit is, because it does work, but it doesn't fix all the problems. Radiation can decrease acute inflammation. Is it going to cure their Graves' ophthalmopathy? Probably not. So active phase management, for me, it's stop their smoking, because that will change their thing. Look at the other risk factors, whether it's the statins, if they've got it, selenium, and then begin the documentation of locational Reynolds curve. Most of these people do not come in acute optic nerve compression. They come in with the other subsequent findings or associated findings, whether it's lid retraction, proptosis that's mild. They're known Graves patients, and what we do is follow them. And what our group follows between 100 and 150 active Graves ophthalmopathy patients at any given time, getting them through their acute changes associated with this. So stop their smoking, start documenting it. Is there a cure for all these people? If they've got mild disease, we just follow them. They don't need anything else. They have moderate disease, we assess how much difficulty they're having, and then we try to get them to the other end of the Rundle's curve, to the fibrotic burned out side 6-24 months later, and then look for the acute people. So my plan is to follow them every 2 to 3 months during active phase and get them to the final phase, and then begin the discussion of what problems they have and what you recommend as far as treatment. So the chronic phase. And people say that a lot of this is cosmetic in the chronic phase. If you talk to a number of these people, they have orbital congestion. They feel their eyes all the time. They have discomfort associated with it. They have pain. And so in the phase where they have a chronic congestive orbit associated with the other end of Rundle's curve, I use a treatment decision path. Because I'm an oculoplastic surgeon, this is where I do most of my intervention. I follow the active phases with our neuro-ophthalmologist, with our endocrinologist. We have a group of endocrinologists that see these patients also. And we keep everybody informed as a team to manage these patients, but it comes down to the chronic congestive phase on the other end of Rundle's curve. I usually wait 6 months of stable measurements, and then I declare them stable. The question was asked earlier, what is the risk of reactivation? In our experience, it's 5%. So somebody's gone through a series of changes, and they'll go 2, 3, 5 years, and then 5% will reactivate their autoimmune disease. So that's what I tell my patients. You look for it, and that's where you go. So back to the decision path. If you're going to intervene in the chronic phase, orbital surgery is done first in our experience, strabismus surgery is done second, and eyelid surgery. I will say that some people just need strabismus surgery, and a number of people just need eyelid surgery, and they need no orbital surgery. So you put up these people and say, where do they follow into this decision path, and do they jump to the third ring? Do they just need eyelid surgery? The large group does. 50% that have significant Graves' orbitopathy may need strabismus surgery and or orbital surgery. So the decompressions, let's take a few minutes to look at decompressions. These are the descriptions a number of years ago. Floor medial wall is more common by many people looking at that, and we'll go through that type. Evaluation of the ophthalmopathy, I start with a CT scan. I do not perform a CT scan at the diagnosis. I perform a CAT scan to assess surgical intervention. So I'm looking for the size and depth of the orbit. A short orbit is much more problem than a long orbit. Size of muscles, position of the sinuses. Do these people have chronic bad sinus disease? Do they not? Do they have large sinuses, small sinuses, and what's the thickness of the bone associated with these defects? And to do that, let's look at orbital disease. Obviously, large muscles, real problem. We know where we're going to go as far as a decompression on this patient, and that's right there. That's where you're going to get the most bang for your buck. What I have learned to do, and I'm not proposing these groups, I just use these subgroups from my decision process within orbitopathy. And if they have proptosis with significant restrictive myopathy, clinically significant diplopia, that's group 1 to me, or the group that I'm going to have one discussion. Group 2 is proptosis with minimally restrictive myopathy. The reason for that is, and I'll go back to this, is the instance of floor medial wall decompression has a known instance of diplopia associated with as a complication of the procedure. These patients already have diplopia, not a complication. You're just going to move their double vision around a little bit, and then you can do strabismus surgery. So I will lean toward floor medial wall decompression for this group of people, and if they need further decompression, go to the lateral wall, then consider strabismus surgery, then eyelid surgery. It's an easier discussion when somebody already has double vision. When they don't have double vision, then you have to decide what you'd like to do with these individuals. And I'll go through the other type of decompression, then we'll talk about it a little bit further. Area of floor medial wall decompression, this is an orbit. I've outlined what we call the strut. And the strut is the junction between the medial wall and the floor. Medial wall, as you can see in this thing, that's the honeycomb of the ethmoid cells. There's the anterior and posterior ethmoid artery right in here, junction to the anterior cranial fossa. This area is game or can be decompressed associated with this. Floor, infororbital nerve, you must identify. I often will denude the bone around the infororbital nerve and decompress the floor. The strut really is the medial wall of the maxillary sinus. And as the medial wall of the maxillary sinus comes up from below, it begins to form this strut, and it's a structural piece that must be addressed a little differently because of what you're doing to the orbit and what you're doing to the maxillary sinus. If you take enough of this out, you may have to deal with drainage of the maxillary sinus, but we address the strut depending on how much decompression we want. I can grade it as far as these areas: first floor, second medial wall, third strut. If I want 6 to 7 millimeters in my hands, I've got to go for all 3 of these. If I want 2 or 3 millimeters, I can go to the medial wall or the floor. I'll go to the floor because it's easy approach, and then I'll go to the medial wall next, and then if I want more, I go to the strut, knowing that I'm going to create more diplopia. Here's the infororbital nerve. And so the floor has been removed. We identified the nerve. When we did this, we kept the nerve intact. And so the bone's been removed here. If one wants to extend up the medial ethmoid, my approach is a transconjunctival approach through the floor. We don't even take the lateral canthus down. We just go transconjunctival, inferiorly expose the orbital floor, remove the floor bone, then take, if I want to extend medially and superiorly up the conjunctiva near the caruncle and up, and allow for exposure of that. And if I can show it, that's the top of the strut right there. So we know where are we dealing with: medial wall above, floor has been removed below, and then make the decision about the strut. As you can see, this patient has fairly significant diplopia. I use neosynephrine or Afrin in the nose and in the sinuses to control bleeding, and then remove this bone in a piecemeal fashion with care to keep the orbital periosteum intact. The last piece that I remove is the orbital periosteum. I incise it. I don't withdraw it, but I incise it, release it, allow orbital fat. If you need more decompression, you can take the fat from the inferior medial orbital area, and as whoever does this surgery also knows, the fat will prolapse anteriorly. So here's our subject, post-decompression. Here he's beginning to go back. We've performed strabismus surgery, realigned him, and gotten his decompression down. So we've taken him through 3 sets of surgeries, floor medial wall, and then on to strabismus surgery, and then lower lid surgery, upper lid surgery, to this position. This does not I mean, what you're getting is somebody with central vision with no diplopia. He may well have restrictive diplopia because in lateral gaze, inferior gaze is the most common, just because the muscles are still abnormal. Another individual, same problem, marked retraction of the lower lids, inability to look down very well, looking up. This is 3 sets of surgery. He has, in my hands, I use ear cartilage to build up a lower lid. That's ear cartilage grafts within those lower lids to bring it back up. But we've accomplished about 7 millimeters of decompression, aligned his eyes fairly well, and gotten him to there. The problem is, I call this the tunnel, and these people are in for 6 to 8 months worth of a series of surgeries, and we try to articulate to the patient, to the family. One quick procedure is not going to fix all this. They have to buy into the process, but if they do, you can take them from significant problems to a fairly good outcome with a period of time, with the caveat they're still got Graves' disease. Do I do 3-wall decompressions? If I need more than 6-7 millimeters, I go to 3-wall decompressions. And as you can tell, this individual had a short orbit, and that's what I look at. If you can't decompress the medial wall, floor, lateral wall in that kind of amount of bone, what you can do is do 3-wall decompression, and you'll see this term malar augmentation. When God gave out malar bones in this individual, she didn't get them. And so what happened is we had to substitute malar implants for this person and then do eyelid surgery, lid retraction later on. But this is basically a face-changing set of procedures. It's doable. It's a series of 5 to 6 procedures to get from A to B. Now let's talk a little bit about group 2, because it's the group that I enjoy doing, but I do a little bit different in my hands. I treat these a little different. And what I'm talking about is a lateral decompression. And over the last few years, people have picked up using lateral decompressions for decompression. And this has been beneficial in my hands for the last 10 years. Lateral wall decompression, possible fat removal. There's a very quiet area inferior laterally in the orbit. You can remove fat and little less consequences associate this. Again, if they need malar augmentation, you can add that to it. And then the last in this group is eyelid surgery with its upper lids and retraction repair, lower lids and build up. This is an individual that had bilateral lateral decompressions and lower lid buildup. I will say that lateral decompressions, I perform one eye at a time. Floor medial walls, I really have no problem doing bilateral decompressions, because if they bleed, if they have a secondary problem, it's going to go in the sinus, it's going to come out their nose. In this group, I had a very nice lady that had a huge vomiting episode in the postoperative time. I did bilateral lateral decompressions, and I had to evacuate hematomas in the recovery room on both sides from count fingers vision. Got her vision back, but I vowed I'd do them one at a time after that. That was more life-changing than I wanted to do. So what's a lateral decompression? It's a lateral sphenoid wing. If you use the new high-speed drills that go 60 to 100,000 RPMs, you can do a fairly significant decompression. And let's see where nothing is here. I will thin the lateral rim. I will find the takeoff of the roof. Bob Goldberg talks about removing this area too, and the fossa above the lacrimal gland is absolutely game to remove bone. Take the bone all the way back to the level of the superiorbital fissure, expose this area all the way to the infraorbital fissure and remove this. If There are a number of ways to address this. Some people take the rim off, some people don't. I prefer the rim off because of exposure, but I have no problem with somebody leaving the rim on and doing this with a high-speed drill. The problem you run into with 60,000 or 80,000 RPMs is you better protect the lateral rectus muscle. I've seen one case that was done elsewhere that got into the lateral rectus muscle. This causes a strabismus that is very difficult to fix. I use ribbons and patties over the lateral rectus muscle to protect it so that if the drill moves or jerks in the wrong area, then it just, it goes into the ribbon or it goes into the patty and the rectus muscle is spared. So be careful in that area. I've had a couple of CSF leaks associated with the superior area. I really don't worry about them. I have exposed dura. And again, that is not a major problem. You can plug a CSF leak because it's not open to a sinus, but it is not something you want. But the dura exposure, as long as you don't open the dura, you'll do fine. So here's a lateral decompression. I personally prefer an upper lid crease incision. You can do it through a lateral lid splitting. Either way is fine. Expose the lateral orbital rim. My preference is to cut the rim free. It exposes the area. This is a high-speed drill with a fine cutting bit that's used in this area to cut away the rim. It exposes the deep orbit. From that, I do a series of maneuvers. I use the high-speed drill. I will use a rongeur, a kerosene, and just expose the lateral sphenoid wing and proceed to remove bone until it's completely taken back to the area nearest periorbital fissure and see what you get. The other is I've found this to be helpful to me. I take the lateral rim out, so I'll take the rim and with a high-speed drill, thin it to half its thickness. People have talked about plating the rim back in place. I will put a small hole above and below on both sides, and this side in the donor area and the rim piece, and just sew it in with a 4-0 nylon. The beauty of that is it allows the rim to shift laterally, and I reported that a number of years ago with a plate, but I prefer just letting it kind of float laterally, and it helps. There is one caveat in closing this. I'll let the lids find their own place. I will not reattach the lateral canthal tendon to the orbital rim because you've released the lateral canthal tendon. It'll pull forward, and that is helpful in the decompression also. You can combine this procedure with a lid retraction repair or recession of the levator muscle, and I'll do that in probably 30% of the cases I do in a lateral decompression. I'll go after the upper lid at the same time. This is a case of bilateral laterals. I wanted 3 to 4 millimeters. This is sphenoid wing drill out. You'll see her incision here in her upper lid. I've recessed her levator a little bit, like 3 millimeters, and I've gone after both sphenoid wings. That's all that was done to this patient. You can get a pretty good result if you do it. Again, one side, wait 6 weeks, and do the other side is my preference. Can you do some fat removal? This is an Asian individual that she has a prominent eye and a short orbit, but I was able to get enough decompression. Again, I'm not trying to make a deep orbit patient out of this, but I'm trying to deal with the lid retraction at the same time the lateral decompression and do both procedures simultaneously, one and then 6 weeks later do the other. Supplemental procedures, preseptal or postseptal fat to relieve orbital pressure and add to the decompression is done. I probably don't do as much as I used to with that. And then malar augmentation or orbital rim augmentation. We talked about the lateral orbital rim, letting it fly laterally. This is a malar. This is a porous polyethylene implant that is, you can find it if you look for these, and this is to replace the orbital rim, and really what you're doing is you're advancing the malar area by 5 to 7 millimeters. It corrects a lot of the perceived exophthalmos because they have malar hypoplasia. So if you have a patient with malar hypoplasia, they have a short orbit, what you're basically doing is lengthening their orbit. Again, malar hypoplasia, no malar bone, really sinks away. What you're doing is just building up this area and giving support really to the lower lid as well. This is what And you can combine this with a lateral decompression if you do a lateral incision. So I'll do a lateral decompression, remove the lateral bone, sphenoid wing through the same incision, put in a malar implant. And this is an individual that's had bilateral lateral decompressions and malar implants. If you look at the drop away, malar hypoplasia is a real problem in this thing because there's no support for that lid. So let's talk a little bit about the future, and then we can get into the interesting discussion because people have great opinions about Gray's orbitopathy. My prediction is that these patients will not require major surgical management of this disease. The nice answer is I'm trying to work myself out of business. I know how to do orbital decompressions. I've done them for years. I've probably done 300 orbital decompressions, and I would love to quit because these patients need something. This needs to be changed to a medical disease and management because it is an autoimmune disease. And so here's my discussion about immunotherapy. And this article was published in New England Journal of Medicine in May 17. Teprotumumab is the drug. It is not available commercially. It's in phase 2 studies. We did part of phase 2 study in a double-blind study. It's a monoclonal antibody that blocks to bind to the TSH receptor on the orbital fibroblast. This is an IgG molecule in the class of autoantibodies that activate cell surface receptors. So it's addressed directly at the fibroblast activity. If you read this article, and I invite you to in the New England Journal of Medicine, I'll give you the caveat. I had 11 patients within the study. We didn't know who got the drug or who didn't, a double-blind study. The p-value is 0.001 for proptosis. For the other findings associated with this disease, it shows great promise. It's a number of years from getting on the market. It's an infusion. But I guess the answer back is, this is again an autoimmune disease. Is there another drug or other drugs that can address this? We know it's an autoimmune disease because steroids and the other things that have been used have effect on this process, but it's not as targeted as some things ought to be. So in the next 10 to 15 years, let's see if we can put ourselves out of business as far as major orbital surgery. I think the lid and the muscle surgery will probably continue because we see the patients after those things have begun to show up. And we'll have a set of patients, as Dr. Bartley said, 7% were euthyroid and they still had ophthalmopathy associated with it. So on that note, I'll thank you for this short rendition of thyroid eye disease. Textbooks have been written about this, but I thought we'd just take a tour and begin the question session. Prior to the procedure, I got a series of questions, and please write your questions now, and I will talk for a minute. I tried to elicit some answers within that. How do I address the active thyroid disease? And the answer is I watch them. I put them on Rundle's curve. I use the clinical activity score. Ugogo has another version of that. Both of them are very good at doing it. Look at them on the internet, get the scoring card, score the patients as they come in, and then watch them for a period of time. Do I use steroids? The answer is absolutely. Do I use them long term? You saw my complication list. I'll use it acutely. I do not put everybody on steroids because of Rundle's curve is different in every individual. Will I use radiation? I personally save that for the very severe. I know there are other people that feel like that's a very first step. What I'm looking for is evidence-based medicine, clinical trials that are proactive, that go forward, that can help in the course of this disease. So I'll start with the first question. Should we include statin in medical treatment? Statin has its own set of complications associated with this. I invite you to read the article. I put it in the slideshow, and if you've got the slides, you can look at it. I personally have not added statins in my medical therapy, but it's something to consider. Again, if you add statins, look out for steroids. The next one is, could you please talk about the course of decompression surgical education? I'll see if I can take that one on. Decompression is something the decision of the patient and I have after they've stabilized, and I want stable measurements for 6 months unless they're an acute problem. Once I get that 6 month of stable findings, then the decision process, how much decompression do I want? Do I need 5, 6, 7 millimeters? I need to go to floor and medial wall. If I need 3 millimeters and worry about eyelids, then I go to lateral wall. Most people with 6, 7, 8 millimeters of proptosis have a fair amount of diplopia. Some don't. I will discuss the diplopia associated with that with the patient, and they have to accept the risk of that. These things are sliding around. It's an individual discussion with the patients. Postoperatively, they'll have some numbness in their face if you do floor medial wall for 2 to 3 to 6 weeks, and then this usually resolves if you keep the nerve intact. There. Let's go. When do you administer periocular steroids? It's an interesting group. It's usually my severe diabetics because they have so many side effects associated with PO steroids, and the others I'll use it periocular. It's not been my best way to do it, but in the diabetics I get around the systemic side effects associated with this. Steroids are, I've been quoted as this, are like horseshoes and hand grenades. You do not need to put it in the orbit. You just put it beside the orbit, right in front of the orbital septum. So you can do that, and I use Kenalog. The problem is there's a known group of people that increase intraocular pressure. You can't take them back out. So you're into the use of steroids for a period of time, and you're doing a diabetic population that has some risk factors. IV pulse steroids, I put it there. A number of people have liked this. I have no problem with it, and I advise you to try it if you wish. And see if this is something you would do. It has some problems in the fact that you have to set it up to get it done. I've just been very happy with PO steroids because I'm trying to run down Rendell's curve. I'll pose the question, I use IV pulse steroids to stop the course of the disease? I have not found that that's been my best activity with that. Do you find selenium helpful supplementation during the active phase? If they have a low selenium level, absolutely. I would put it in. Has there been prospective studies to say it makes a big difference? I'm not sure of that. So it's easy. It's a multivitamin. You just look for the multivitamins with selenium in it and say you can take these and it may help it. So retrobulbar triamcinolone for orbitopathy, again, I don't put it retrobulbar. I put it peribulbar right in front because it's close to there. Can a wider lateral orbital wall angle on CT predispose, this thing is jumping around, excuse me, predispose to the patient for more severe disease? I'm not familiar with that. Well, they said a shallow orbit, absolutely, because you're starting from a proptotic eye to begin with. Should tarsophy be done for exposure keratopathy? Sure. It's something you can do to buy you time. Again, you're looking for Rundle's curve. You're trying to get them to the chronic phase, and if you need to do a tarsophy then to get them down the road, absolutely. I do not use long-term tarsophies though, because there are too many other options, and the usual tarsophy answer is, and I did this with facial nerve palsies, it's like a horse where you put blinders on the side. Their field of vision's affected greatly, so you'd like to give them a long-term experiment. I have one question. Thank you, doctor. I remember a patient that we had steroids made him manic, and we needed to manage him with the help of psychiatrist. Every time he came in with acute inflammation, we ended up improving with radiotherapy. What I tried to do with this was say there's a number of things people use. All of these have effects and side effects. Radiotherapy is not benign. Also, it has its own side effects. So this is a complex disease, and we don't have a full control of this disease. How long should corticosteroids be performed for the acute orbitopathy? Would you consider another modality? I use a relatively short course. If you look at the IV pulse thing, it's for a short period of time. I really use PO steroids, and I'll use it for a week or two and then start withdrawing it or look at what other modalities I may need. If I have a severe problem, I'll go on to radiation therapy if I'm not in the chronic phase, or I'll consider decompression if their vision's down because I don't have the beauty of being able to wait. Again, look at their severity of active disease. Please do not use all these modalities from mild to moderate disease. They're going to get through all this. When would I consider rituximab? I've used it 2 or 3 times. I've not been greatly impressed. It's the old answer is when your back's against the wall and you've used everything else, and what else can you use? I'll probably pull it out. I'm looking for new drugs that are aimed better at the disease process. What's the duration of steroid therapy, oral or periocular? Again, the same answer. I use it a few weeks and then I'm off of it. You saw my picture of 40 pounds and diabetes. If you're at 2 months, 3 months, you're really not changing the course of the disease. Periocular, 1 or 2 injections and I'm done. How do you treat retraction of upper lid medically? That's an interesting question. It's been proposed to use Botox to cause paralysis of the levator muscle. It has its own side effects. It lasts 3 to 4 months. If you have somebody with exposure, I've used it a couple of times. It is not really predictable. So if you have somebody with real exposure, you can try it. It has, I mean, you can give enough double diplopia and other things. It's been reported, and occasionally I'll pull it out, but it's not a great treatment for it. Surgical is the correction for upper lid retraction once it's stable. Next question, during decompression, if the let's get it sliding. Okay, if the dura is open, is there a chance of CSF leak? Of course there is. I'm not a neurosurgeon. Can I manage the patient? If you've exposed dura and there's a small leak, I'll put gel foam in it if there's no leak from there. Because it's a closed space on a lateral, I don't really greatly worry about it. I have exposed dura 2 or 3 times, and if you see the dura and it's intact, there's no problem at all because you're doing lateral decompression. If you need to, you can call in a neurosurgeon. They can put in a lumbar drain later on, and then you look for lower the pressure, and it'll self-seal in a group of people. The more complicated problem is somebody that performs a medial wall decompression and gets an incidental CSF leak. Now you do need a neurosurgeon. You do need to manage it because CSF leak goes into the ethmoid. They're at high risk for meningitis. If you're doing a lateral, the risk for meningitis is almost nil because it's not to an open area where there are bacteria, it's to the orbit. If the patient has just mild unilateral lid retraction with euthyroid, how do I treat? Back to Rundle's curve. I watch them for a period of time, and then the discussion comes down to a 6-month stable finding, and is this symptomatic to the patient? Do they wish something done? If it's 2 millimeters or more, I will address it as a functional problem because they get some lag ophthalmos at bedtime. They have to use lubricants, and so it's all patient individual treatment. What should the time difference be between different surgeries? Orbital floor decompression, I send to my strabismologist probably 6 to 8 weeks, and they want to get 1 or 2 stable measurements before they proceed on. Again, they're looking for stability in this course of the disease. My lateral decompressions, I'll do one side and then wait 6 weeks and do the other. Eyelids, I want all the swelling and the inflammation to subside, and then I'll address the upper or lower lids accordingly. Anonymous attendee says, UGOGO classifies thyroid eye disease as mild to moderate to severe and sight-threatening. How do we differentiate between moderate and severe disease in this classification? Okay. I'll take this one a little bit down the line. Use either the UGOGO or the ITEDS or the clinical activity score and start looking at those. If you're treating these patients, pull those scores up and start plugging them into your patients is the first thing. The next is my severe disease has to do with severe exposure or the second is optic neuropathies. Do I have a decrease in vision? Do I have a decrease in color vision? Do I have a field defect? Do I have an afferent pupillary defect? All those things are signs of optic neuropathy. And so I'm looking for optic neuropathy in those patients. Next question, is surgical decompression repeatable in some cases during the course of the disease? Absolutely. And you have 3 walls. And if somebody comes in that's been treated elsewhere, the first thing I'll do is a CT scan and see how complete is the decompression been performed. Has 1 wall been worked on, 2 or 3? Once you're into 3 walls, then and you've gotten enough decompression in all those areas, I think you're done. You may consider some of the other types of treatment, orbital fat removal, and then you go from there. Is radiation been used? All the other things that are out there. But you're in trouble after you've taken 3 walls and you're still having problems. Do you consider low-dose methylprednisolone, such as half a gram a week in acute inflammatory phase in the absence of sight-threatening conditions? No, I do not. This is it's back to Rundle's curve. There's a number of people that have just lid retraction and nothing else. So I'll let these people kind of show where they're going and what they're doing before I pull the trigger on known side effects producing medications, drugs. How do you decide how much decompression is needed? This is an interesting question. Hertel measurements are variable by facial contour. Look at how much lid retraction there is, how much I'd like to achieve, and I look back at their history. And what I mean by that is most people have old pictures, old photographs. And I say, bring in your old photographs and let me see how much proptosis you've really has occurred in you. If somebody, as you saw, I put up an Asian patient and she's got a fairly proptotic eye to begin with. That's the way her face is. So I'm trying to get back toward normal. And so what I want to do is look at ID pictures, old pictures, let them bring them in, look at it and see how much decompression I would be aiming for. Is it 2, 3, or is it 6, 7, 8? Okay. Thank you very much. I appreciate it, and I'll welcome any further questions later on. Thank you. I'm signing off.